plan followed what I think is adequate for this time, for this age. She's 6. So we went ahead with rapid maxillary expansion, face mask, and after 8 months, we went into functional jaw orthopedics. We used orthopedic appliances to maintain the corrections. Prognosis, guarded, depending on compliance and growth. Probable additional ortho treatment with fixed appliances during puberty. So, of course, I foresaw that this was might be one problem with this patient, that she would need another phase of treatment. So this patient is being treated for 18 months of treatment. That's the plan. And then she will be followed every 6 months. She will come to the office just for follow-up. And when she exchanges all the baby teeth and she has the second molars in the mouth, we'll start phase 2. So that was the original idea for this patient. I'm not going to go through all this phase of treatment just for the sake of making the presentation a little bit more dynamic. So when she was 11, after we went all through this first phase, RPE, face mask, and functional jaw orthopedics, we used removable appliance for functional jaw orthopedics. And she was at this stage, she's 11 right now, and she has a class 1 molar, class 1 premolars, and she has no room for the upper canines in both sides. So we had exchanged the problems that she had. She had a class 3 malocclusion. Now she has a class 1 malocclusion with crowding. And also the overbite is very shallow. The overbite is very, very shallow. So here's her SAF, and we can see that now we have a better setting to start off treatment, because we were able to give her a better balance between the maxilla and the mandible with very simple mechanics. And now the maxilla is well positioned, is a little behind the line. The vertical line should be on the line, is 2 millimeters behind. And the mandible, the pogonium or point B, is behind the line by 4 millimeters. So that's acceptable. I felt confident that I could treat her with just orthodontics and no surgery. So that was the idea. So here you can appreciate both SAFs, left and right. On the left side, she is 6. On the right screen, she is 11. So there are 5 years separating both. And she was treated for 18 months and then a follow-up of 3.5 years. So now she's ready for phase 2, or as we call it. And here we can see that there's no room for the upper canines, and also the lower canines are blocked out. But mostly the upper canines need more room to erupt. So what I decided was to present a treatment plan that makes sense. And for Ana Julia, now she has a straight profile, a slight mandibular prognatism, which is acceptable, and crowding. And treatment plan was for phase 2 was fixed appliances, 4 premolar extraction, splice closure, and retention. And the estimated time was 24 months. So now I felt that the prognosis now was favorable. So I said, I think that as with the age that she is, we can treat her with regular orthodontics and no need for surgery later on. And what happened was that parents declined treatment because they felt that they wanted to avoid extractions. And I really made a point that I really need the extractions in this case. And they declined, even though they had me treat their daughter on phase 1. When I mentioned extractions, they declined. And they said that they wanted to hear a second opinion. I said, okay. And I gave them the records and stuff, and they disappeared from my office for some time. What happens is 4 years later, I came to my office and looked up in my schedule and saw her name. I said, I don't know why she's scheduled for me. She didn't want to be treated. And she came in, I almost fainted because was a total different person that I had in my mind. I had in my mind that beautiful little girl with balanced lips, with a beautiful profile, and whoever entered my room was not the person. I almost cried when I saw it. And these are the records that were taken when she came to me. And I have better pictures. I'm going to show it to you, but we can see that the canines are in the mouth. But the cost of these two canines in the mouth is that now she has a bialveolar protrusion. She has no overbite. She has no protrusive guidance, no lateral guidance. She has a different malocclusion. So what happens is sometimes orthodontics does that. We just exchange malocclusion. You have one malocclusion, it's exchanged for another one. In my opinion, a worse one, because patient here has no way of having a normal function. So here you can appreciate what I mentioned to you. On the left screen, you see her at 11, and on the right screen, you see her now at 15. So 4 years between these two x-rays. And she was being treated for 4 years. When she left my office, she was 11. I planned her on doing her treatment in 2 years. And now she's 4 years later, still with braces. And I almost, as I mentioned before, I almost cried when I saw, because I almost didn't recognize her. Her face looked distorted. Her face looked too brutish, too protrusive. And I thought to myself, gee, it's something
I'm
very...
sorry. I'm sorry, Dr. Ursi, for
Yes.
interrupt your webinar. But your right side of the presentation is cropped, some small cropped.
Okay.
So you can stop the. Oh, okay, it's good.
It's good now?
Yeah,
Okay.
thank you very much.
Is it still okay?
Yes,
Okay.
yes, okay.
So here are the pictures of her mouth. And this is not the standard of care that we teach here. You see, excess of composite on the bondings. And this is terrible. This is awful. And this was the place that she was taken to be treated. And this is below whatever we might feel it's acceptable in doing orthodontic treatment. And, comparing to the way she was before, and now she's worse. She has the canines in the mouth, but she has, totally lost whatever she had good in her occlusion. The molars are still in class 1, almost slipping into a class 3, and the lower incisors are procline, the upper incisors are procline, the canines are in the mouth. And compared to what she was before, in my opinion, is much worse, because I wouldn't attribute this to crowding. This was caused by orthodontics, bad orthodontics. That's what I mean. So a lot of people today talk about the no need for extractions, that we don't need extractions anymore. And I think this is not the way that the profession should be going, the specialty should be going, because we still need sometimes to extract teeth. It's not a matter of squeezing teeth into the mouth that will make our patients happier and better. So she doesn't have room for the third molars. Third molars are going to be blocked out. So she runs the risk of losing premolars and third molars now. No lip support. So the lower lip is everted. The upper lip is short. She has a good nasolabial angle, but she looks too protrusive. So this is not standard of care. So she was treated, Ana Julia was treated, as I said, for about two years, a little bit more than that. And we used a sequence of wires. We had extractions of the fives, the second premolars were extracted. We used elastics for anchorage. We didn't use any TADs or any headgear or any other appliance in either in the palate or in the mandible. And that was the wire sequence. We used copper night ties, 13, 16, 1425, 1825. There was a period that I used some stainless steel wires. Then we finished with 1725 stainless steel wires. There was my final wires. We could go up to 1925 if we needed more torque, but I felt comfortable with the torque I had at these wires. So here is 5 months into treatment. 5 months into treatment, we had then the extractions of the 4 second premolars. The overjet already looks like it's more under control. The overbite is progressing. She is wearing class 2 elastics to close the space in the lower arch. This is 15 months of treatment. She is with 17 by 25 stainless steels wires, which were used till the end of treatment. So, of course, when we get to this point, we have to close the spaces, which are residual spaces, and the patient thinks that we are done. In fact, we are not done. We need another year to finish this case properly. So it took us more than expected. I had expected 24 months. It took me 26 months of treatment in order to get to this. So now I'm happy. Of course, the overbite is not deep. It's a little bit shallow, but I think that the result and the protrusive guidance and the canine guidance could be established with this overjet. So particularly when we compare before and after, we can appreciate, how much we could do for this girl doing regular orthodontics, nothing fancy. Took me very little time. I saw her every 8 weeks. So I treated her in 26 months, but I saw her like 14, 15 times during this period. So we could get proper canine guidance, premolar relationship, molar relationship. So we were very, very happy at the end. And by comparison, when you look before and after, we can appreciate what adequate orthodontics does to a patient. So at a time that our specialty has had so much attacks from companies, from advertisement, from gurus in orthodontics, we have, as specialists, as professors, elevate the level of our cases so we can compete in the market. So here's the left side and the occlusal views. And I feel that the conclusion to a case like this, what we learn from a case like this is if we have a combination of larger than normal teeth, so we have to measure teeth all the time, every time that we treat a patient, plus crowding, plus protrusion, we still need extractions. We might have a debate here if it's going to be premolars or it's going to be second molars or even third molars. If you decide to extract third molars, then you have to use TADs in order to retract teeth. And you might opt to extract second premolars, as I did in this case, because they are smaller teeth than first premolars. They don't show when you extract them. They don't appear in the patient's face when they smile. And you expedite space closure. So today I extract more second premolars than first premolars. in every single case I treat, except when you have too much protrusion. Her protrusion was a little exaggerated, but I got by extracting second premolars. Second case. So this is an older patient, and she came to me. She was referred for evaluation, and she presented missing teeth. She had 3 teeth missing. She had number 12 missing, that's upper right lateral incisor, and 2 lateral incisors, numbers 42 and 32 were missing, and she had to have them replaced. And what we can observe in this picture is that she had, a lot of overbite. Her overbite is 100%. She had also overjet. Her mandible was short. Her face was short. So in a case like this, it's very difficult that you might accomplish guidance with such an overbite, because the anterior guidance is going to be too large. And also she had like a class 2 relationship. You can observe in the molars a class 2 relationship, particularly on the right side. Just a second. Okay. So here's the upper arch and the lower arch.
Dr. Ursi, there are still a problem on the right side of your screen. So can you restart the sharing, stop the sharing, and restart share your screen, and choose one screen for presentation. I will stop your sharing.
Okay.
And now,
are we okay now or not?
Yeah, okay. It's okay, and you can share your.
Let's leave it like that. Is it okay?
Now you can share your screen. Choose one.
Just a second.
Yeah, I think it is a problem of internet connection.
Yes.
Yeah. If you move, okay.
How are you now?
Yeah,
fine?
That's great. Okay. Yeah, fine. Thank you.
Welcome. So you tell me if I'm doing okay, okay?
Okay, it's okay.
So she has here her pants, and you see that she has room for the upper lateral to be placed, but she has no room in the mandible. And also she has this big overbite. So and the mandible is retrusive, and the lower incisor are retrusive. So I start thinking, I don't know, I think we'll have to, prepare you better for you to get your implants. There's no room here for you to place the implants because the roots of the central incisors, they are divergent. So we had to optimize this. And what's funny is that this is the phrase that the other orthodontist used for her. The other orthodontist told her, your treatment is finished. You are now ready for implants. So this is actually the end of her treatment. Not my treatment, but this colleague's treatment. Told her, you're ready to do it. Go ahead and do your implants. You're done with orthodontist. And I don't feel that, with all honesty, I could tell this patient, yes, I agree. She came with a second opinion. If I thought that this was okay. And she lives from another city. She had to drive like 2 hours to my office to hear my opinion. I had to be really honest with her. I wasn't happy with this result. And these are the records before she did her treatment. That was before she initiated her treatment. And we can see she still has the space, not the space, but the canine next to the central incisor. Here it is. So actually what treatment did was procline the upper incisors and open up space for implants here. But the thing is, while this was successful in the upper arch, I don't disagree, I think it was fine. In the lower arch, wasn't that okay? And this is her before. You can see that the teeth are already tipped out. And when the spaces were open, they continue tipped out. So this was before she started her treatment with me. And when she got to me, she was like this. So I have to redo her treatment, and I have to place these two teeth parallel to each other, and I have to resolve the class 2, the overbite, and the overjet. So I decided this case was for orthodontic surgery. So I planned her for that. I'm going to redo her ortho and set up her for mandibular advancement and maxillary downgraft. So we are going to move her maxilla forward and down and her mandible forward. So when a force was applied here with coil springs to open the space, automatically what happened was that the root went the other way. So when we do this mechanics, we have to be very careful with first what wire we are using and what kind of coils we're using. And this picture, this x-ray, in fact, was from the previous treatment. So I know that because we can see the ties here, the metallic stainless ties, while I use a self-ligated bracket. So this was before, not mine. So the pen in the top is her before the ortho treatment. The pen in the bottom is after her ortho treatment. And while the space was good here to place an implant for the upper lateral, here it's not good enough to place 2 implants in the lower arch. And also has the problem with the overjet and the overbite that bothers me very much because I don't see patients functioning with that much overjet and overbite. So this was when she started, November 2007, and here's March 2010. So 2.5 years later. And the teeth already are still crowded. 7 months later, when I started treatment, I was preparing her. I was leveling in alignment. We have a progress treatment pen, and you can see here that the room for the lateral is preserved. I didn't decrease it. In fact, I opened up a little bit more. And here now the teeth are parallel. Both central incisors are parallel to each other, and the canines are vertical. So now we have room for implants in the lower arch. So she's being set up for orthodontic surgery. How about this patient's photos? I don't have her intermediate records, and I'll show you why. I got this email in May 2017 and was from a hacker exploiting me and asked me to pay him or her, I don't know, 2 Bitcoin. I don't know if it ever happened to you, but they encrypt all your files. So this guy, he got into my system and encrypt all my files and was asking me a ransom for me to pay him. So he would give me a code so I could open up my files. In fact, happens last week with a big company in the US, Garmin, Garmin. They make avionics, GPS, they make watches for running. I use them in my bike, I'm a cyclist. So no GPS. They hacked inside and they were wanted money from Garmin. That's they wanted money for me. I talked to my IT guy. He said, "Don't pay, don't pay because they might have planted another one, and they are going to ask for more money later on." So I decided not to pay, and I couldn't decrypt a lot of my files. But I have the final pictures I retook. So I'm just explaining why I don't have the intermediate. So one Bitcoin today is July 2020 is $9,000. And this guy was asking for 2 Bitcoin. And I said, no. And he said, he was threatening me. He said, 2 Bitcoin today and tomorrow is going to be 3. After 48 hours, the price will grow. So I said, I'm not paying. And, you know, he even was not nice to me because he said, your files were encrypted because you don't give enough attention to safety. That's really, I'm sorry, but I really got mad at this. I said, I'm not paying this guy. So no matter what I lose, I'm going to lose a lot of files. It's okay, I start over, but I didn't pay. So that's why I don't have intermediate records for this girl. I have final records. So this is she after she did the orthodontic surgery, which was maxillary advancement, downgraft, and mandibular advancement, plus 3 implants. She was very, very happy with treatment. We are friends on Facebook, so many times we text each other. She's a very nice lady. And I think I'm not going to discuss the aesthetics of the implants or the crowns because it's not my area. I don't do them. But I think the final occlusal result was very fine. Now she has adequate overjet, canine relation is good, and also overbite principally. So that's an example of things did not go well and the way that we have to fix it. Sometimes you have to really redo the whole treatment in order to get the patient into acceptable results. So here she is. She's very happy because she was too old. She looked old in these pictures, and she looks much younger 3 years later. And when you fill up the face, you bring forward both the maxilla and the mandible, you get a real nice result that's not comparable to anything plastic surgeons can do with fillings. This is permanent filling. She has better function, better nasal respiration, and better facial balance. And she has gained 10 years. She looks 10 years younger than what she was before. She was very, very happy. And I was too, of course. And here you can appreciate the final cases. So conclusion for this case, when opening spaces for implants, compensate bracket placement. Use full-size arch wires. And most importantly, keep forces to a minimum. That means keep the forces of the open coil to a minimum. I use Damon brackets. I only activate the open coils. They are night-tie coils, half a bracket, only half a bracket. So here, when you're going to bond this teeth, you have to compensate the bracket placement in order to close the roots, make them parallel to each other, at the same time that you're closing the space in the crown. And that's the same thing for the canines also. Keep the canines with the roots more vertical, so you have to diverge the roots while you're using the night-tie coil. But most importantly, keep the forces low so you don't have too much side effects. So going back to what was the beginning of my presentation, we have 2 types of orthodontics. And now I'm going to show a case which I was proactive. I didn't react. I act before it happened. And it's a very simple case that we see today because we think we took the time to prepare the mechanics to decrease or eliminate side effects. And orthodontists are people who sometimes they jump into treatments while they should be more careful with treatment planning than doing things and then have to redo things. So the more time you take planning, the less time you take treating. So if we go through the process of how our specialty is today, I would say that I use a straight wire for the past 35 years, but I think segmentally. I don't do, burstone segmented mechanics. I use straight wire mechanics, but I think segmentally. So I use the best of the two worlds, in my opinion, to get the fastest way to the end of treatment. So in my case number 3, this is Amanda. And Amanda, she came to treatment because her parents felt that her teeth were crowded. And what is interesting, she was very young. She had lost already the canines, the lower canines, and the two laterals, the permanent laterals, they were 90% rotated. So here you see 90% rotation. And that's not very common because if you observe the size of the tooth, it doesn't correspond with the space. It means that when you have a tooth that's so rotated, but you still have space, you have a little space mesial to it and distal to it in both sides, it means something else is provoking this rotation. In this case, was the upper canine. Here, if you rotate this tooth, it still needs some room, but it's overly rotated for the amount of space that it presents. So here are her study models, and we can appreciate her ceph, and looks like her canine is parallel. The long axis of the canine is parallel to the long axis of the central incisors, but a little palatal to it. So probably at those times, we're talking about 1999. So we didn't have CBCTs at those times. So we had to use old-time diagnosis, which is a ceph, sometimes periapicals, and panoramic X-rays, and really hope for the best. And here you can appreciate that that's exactly what's going on. Both her canines, they have lost the direction of eruption, the eruption path. They have left the position that they should be occupying, which is right above the apex of the canine, the deciduous canine, and they are touching, in a way, the roots of the lateral incisors. That's why the lateral incisors are so rotated. So we have to intercept this, and we cannot do something that's be a big mistake. For example, trying to derotate these laterals now, because the patient came to me for that. I don't like my laterals. I want them corrected. And you don't have to do what the patient asks. You have to do what the patient needs. And she doesn't need this right now. She needs her canines away from the roots of the laterals. So here's a close-up, and you can appreciate the overlapping of the structures. They are very close together, and both roots of the deciduous canines, they are complete. Oh, there's no resorption. So we have to do something to intercept that. So that's what we did. We used a very simple, I like simple mechanics. I don't like complicated mechanics, and I like protocols. I use protocols. So the protocols for a case like that is gain space and extract the canines, the deciduous canines, and wait 6 months, another pen, and see if there is any change in the canine. So the protocol was gain space and extraction of teeth 53 and 63, which are the two deciduous canines. So the expander stayed in the mouth for 6 months, and now she's just using a removable Holly retainer, and we are going to have a pen to see what happens to her canines if they're coming down or not. And the two of the laterals, they're still rotated, complete rotation. In fact, they are improving. 6 months later, they are improving. What do we have to do now? Exactly, nothing. We don't do nothing. We cannot touch the laterals still. The patient is of course, is not happy because now she has two rotated canines and she has these two big spaces in her mouth. Not happy at all. But again, you have to do to the patient what the patient needs, not what he wants. Another 6 months, these teeth are coming down nicely. What do? Nothing, you wait. You can see that the roots of the laterals, they are fine. There is apparently no resorption. And now they appear in the mouth. First, the left, and a little later, the right canine. And only after these teeth are in the mouth is that you're going to start your ortho treatment, because now you're sure that the roots of the laterals are safe. It's safe to touch these teeth. So we have problems here, biomechanical problems. We have teeth which are rotated 90 degrees. So you have a big rotation here and here. It's a problem biomechanically, because when you have a teeth that's rotated this much, you have to plan what you're going to do not to affect the teeth which are closer to them, which are these two central incisors and the canines. So what we did is very simple. As I said, the solutions I find biomechanically, I try to be as simple as I can. And that was increase interbracket distance. How do you increase interbracket distance? Do not bond the central incisors. Do not bond the canines. So I bonded only the molars, premolars, no bonding on the canine, no bonding on the central incisors, and the other side also. And you're seeing that these teeth are already rotating. They rotate like crazy. And here are regular brackets. It's not even self-ligated. They are, at that time, I used regular brackets. So they rotated very fine and very easy and no complicated mechanics, only the wire. You have to think that as you increase the distance, the force decreases on these two teeth and also on the anchorage. So the anchorage doesn't move. And there's no additional anchorage. There's no palatal bar, no implants, nothing. So nothing fancy, very simple, down the earth, regular orthodontics. Just a second. And continue with the case. And now these laterals are okay, and the centrals are brought into the arch. We bonded the centrals. The canines are coming. They arrived in the arch. They are bonded. Now I have a full stainless 19 by 25 arch wire. I take a pen, see that I need some adjustments. This lateral is a little bit tipped to the distal. It should be, and this also too, they should be more parallel to the central incisors or a little convergent. But the roots are okay. The roots are fine. So here's Amanda, 2004, when we removed her appliances. She's a teenager now, 2004. Let's follow her through her years, how she aged. Before and after. So here's 5 years later. It's still maintaining good position of the canines. The gums look healthy. Occlusion is okay. It's acceptable. It's not perfect, but it's okay. That's 2009. She lost her Holly retainers. Now she's not wearing anything on the top. So I'm worried about the stability of the correction of the rotations. She's only left with the 3x3s, lower arch. And now that's 10 years later. The other photo was 2009, now it's 2019. And this is Amanda. Very beautiful girl. And this is her occlusion, 2019. Of course, she aged. She's different. But I think she maintained what she did best. What we did best for her was to do an ortho treatment, an interception of a problem, mechanically sound, and no problem whatsoever to her gums. And luckily, reasonable stability. Here we can see a small rotation developing, but she's not interested into wearing retainers at this time. Here's the lower arch. We are keeping the 3x3s, the fixed retainer for her. That she agrees to wear. Conclusion. Interception of ectopic canines needs spaces larger than the canine itself and extraction of the deciduous canines. The spaces can be developed by RPE or by extraction or by distalization or proclination, I don't care. But you need space. And the space between the distal of the lateral and the mesial of the premolar has to be larger than the canine. So if you can get like 9 millimeters of space, perfect. And what you do then? Nothing. You wait and you take a cone beam or a panoramic X-ray 6 months later. And number 2, increase interbracket distance to decrease side effects. Well, I'm approaching 50 minutes of my presentation. I have one more case, which I find very interesting case. I hope you like it too. So this girl, she came to my office wearing braces. No orthodontist liked this situation when a patient schedules an appointment and shows up wearing braces, because something must be wrong and you have to deal with this problem. And this is the problem that she's facing right now. And she's not happy. She's been in braces like forever, I don't know, 3 years, 4 years, whatever. And she told me, my teeth were not like this. My teeth, they were not perfect, but they're not like this. And now I feel that my teeth are moving. And I don't like this. And I can feel something inside my mouth. Oh, you feel something inside my mouth? Your mouth? Let's check it. So that's what she feels. That's the apex of number 32. Apex of number 32. So I asked her, since when are you feeling this? Oh, for this past 2 months. And what happened during this time? Oh, the dentist that saw me was activating the wire to try to bring my tooth, which is not erupted. So this also, there is a canine, number 33 is not erupted. And the other orthodontist tried to bring him to the arch, and is causing a secondary effect, a torquing effect on number 32, on the lateral incisor. So it's giving labial crown torque, buccal root torque. And the apex of the tooth is almost in her mouth. And now she is in big trouble, and she's almost crying when I was, examining her. She was desperate. I went to another dentist, and the other dentist said that I'm going to lose this tooth and this tooth, I'm gonna lose 2. I said, Jesus, we have to do something for you. This is not accepted in my profession. And this is really, really, really something to deal with. And this is her ceph at this time. And you can see that she's protrusive. And when I check closely, you see that these teeth are all over the place. And she has, you know, a occlusion which is not acceptable. On her PEM, we can observe a canine that's being tried to be brought into the arch, and you don't see the root of the lateral. You don't see the root of the lateral because it's out of the pictures, almost out of the mouth. So this is a nightmare. It's a nightmare. And I said, and what can be worse? And well, she said, what could be worse? She said, I can't pay you. I said, don't worry about that. We'll deal with it. And he said, how much it's going to cost? I said, I don't care. You go outside, and there is my secretary, and you're going to tell her a number. I don't care what number. Whenever you tell her, that's the number, the figure that you're going to pay us. And use your conscience. Whatever you can pay us is going to be acceptable. So I treated this patient for whatever she could pay. I don't remember which was the amount, but I felt so terrible for her that I said, gee, we have to do something. We have to do something. And so here the periapicals, and you can, the image actually is pretty amazing because you can see the bone trabecula from where the tooth came about, and there is still some remodeling of the bone there, so you can see where the tooth was and how it moved up. So the tooth actually has moved up, but has been moved up with the wrong mechanics. First, there was no room for it to be brought, and the place where the bonding was done, the button was done, was totally wrong, because this is making a movement, a bodily movement. So the tooth is moving bodily up, while you have to tip. When you have these cases, you have to tip teeth. You have to tip the root to one side and the crown to the other. So actually the bonding is wrong. The biomechanics is totally wrong. So I'm a friend with a local laboratory that takes cone beam, and I asked a favor. And I said, we need this cone beam for this girl. She can't pay. So whatever you can do it, I'll pay for her. So I actually ended up paying for this cone beam also, because I needed to have a view of that. And when I saw the cone beam, I was very much distressed. What we can do for this girl, because here are the teeth. This is number 32, and the root is totally out of the bone. And here somewhere is number 33. So let's see her records before treatment, before she endured this. She was a beautiful girl, very balanced face, very good occlusion. She didn't have a tooth in her mouth, which was the canine. So all the treatment that was done, orthodontic treatment that was done, was something really terrible for her occlusion, because disrupted whatever good she had. And now we have to deal with it, because it's our interest that our specialty maintains the highest quality possible, so we can have a good place in our society. And here you can see how she was before. Beautiful balance. She's, you know, black. She has a little protrusion, but that's totally acceptable. She's a beautiful girl. And this is actually the pen before treatment. So you can see that the canine is very low, close to the border of the mandible. But you have to know that in this case, if you're going to try to bring this teeth to the mouth, biomechanically you have to plan open space, more space larger than the size of the tooth by 8 millimeters, about that. And then you have to place the bonding precisely on the tip of the tooth, not on the middle of the crown. because if you place in the middle of the crown and you pull a direct vertical force, you're going to have a bodily movement, and it's going to cause a disaster like did in this case. So I took out all her brackets, cleaned her teeth, took these pictures, and waited a couple months to restart her treatment. This is a close-up. So here is where approximately the crown of the tooth is. A close-up. 3 phases. Left screen is before she started treatment. Center screen when she got to me. Right screen after I took out her appliances and left her a couple months without anything on. Right side, left side. It's incredible. If you look at this lateral incisor and compare to this lateral incisor, how can orthodontics do that? I can tell you, force and placing biomechanically unsound principles causes this. And here is the pen before and after while she was in treatment. So as I told you, it's the wrong place of force application. You cannot place here. You have to place on the cusp tip. If you place there, this tooth is going to move bodily, and you don't want that. You don't want that. So you need to place in the cusp tip always. The right position is where this arrow shows, cusp tip. You don't have much room, doesn't matter. It has to be there. So you can have uncontrolled tipping. Uncontrolled tipping meaning the crown goes one way and the root goes separate ways. So uncontrolled tipping, not bodily movement. So let's start her. As I told you, I like it simple. So I placed a lingual arch as anchorage. I didn't bond number 32. So I didn't bond this tooth before I started. Had a friend open up the gingiva for me to bond a button right on the cusp tip and start pulling this tooth slowly back with just a coil. Simple biomechanics. The first thing you have to do is bring this crown away from the root of number 32. First, bring it back and then bring it up. Because if you try to bring it up as it is, you are going to run into more contact with the root of the lateral incisor. Here you can appreciate the way I'm doing. I'm just pulling lightly, very light. You can check that this coil is like 50 grams of force, very light, pulling back. This is a month after. It's already, the tooth is moving. And then I went to cantilever. I'm using a cantilever with a TMA wire, 17 by 25 TMA wire to make more of a vertical movement, since now the canine is not in contact with the lateral anymore. So as I pulled it back, it also erupted and tipped back. So I'm going to erupt it vertically now with no force on these teeth here, because they already compromised. The bite is open here. It was opened with this biomechanics that I was using before. So I'm going to use the molar as anchorage. And when that tooth moved a little bit more, I bonded it. And no bonding on number 32 yet. Forget about the lateral incisor first. You have to deal with the canine first. Save the canine. Then deal with the lateral. You're not sure if the lateral is salvageable. She might lose it, but at least I saved the canine. You still have some young tissue here. Here you can appreciate the lingual arch. I'm bringing the canine. Now I need this canine. The root being positioned more inside the bone and the crown more outside. So I need labial crown torque on this canine and lingual root torque. So what I did is I rebonded this bracket. I'm going to rebond this bracket, and I'm going to use what we use in Damon system is called a high torque bracket. So it has 13 degrees, positive 13 degrees. It's a lot of labial crown torque, a lot of lingual crown torque. And of course, this wire has to be increased up to a 1925 TMA. Why TMA? Because the level of the force is smaller than using a stainless steel. Now we don't see anymore the apex of this tooth because the torque is working on this tooth also. So you have two different torques here, two opposite torques. This torque is labial crown, and this is buccal crown, two different torques. So we have to anticipate this. Of course, with this much movement, this tooth is suffering. It needed root canal. It discolored, it lost sensitivity. So you need to have a root canal done, which is the least of the problems for this girl right now. And we got to the point, and she was, tired of all of this. And I said, okay, let's remove the appliance. But I think she was very, very, very happy because I saved her two teeth that were almost sent to be removed. So this is the retainer we use for her. And you need, in this case, that you did a lot of torque, you have to bond the lingual retainer on this tooth because the fibers, the gingival fibers will tend to untorque it. So you really have to stabilize it on the wire. A close-up, you can see that the gingiva is fine. Of course, if you take a probing, if you probe this, you're gonna have, a big defect around this teeth. But if she keeps it very well cleaned, she can keep this teeth for a long time. So here is some time afterwards, and checking of the gingiva is still fine before and after. I'm right. Finishing this is about 2-3 years after we got done. And the tissues are fine and the girl's fine. And I wanted another CBCT. And so I actually asked her to take the CBCT, and I ended up paying for the CBCT also because I needed the images to use as a professor to use in my presentations. So here are the teeth all around. This is number 43, which is the right canine. 42, 41 are fine. 31 is fine. 32, you can see that the apex is very close in position with 31, but still you can see there's lacking some bone in the lingual, but the tooth is relatively stable. And here is the canine, number 33. And you can see there's still, you have some lacking of bone on the labial surface, but the tooth is stable and it's not movable. And so here's the reconstruction of the mandible. And you can see that apparently there's bone covering. And we compare before and after the amount of tooth movement that was done in 2 years. It's, for me, it's very exciting. I love this case, not because I did it, it's because what our specialty could have done for this girl. And you can see there's, this tooth was lost. Number 32 and 33 was lost. And losing these teeth, she would need a lot of repair, a lot of surgeries to make up and substitute the missing of these teeth. Conclusions, I have 2 for this case. Enclosed eruption, canine traction, bond accessory on the cusp tip. I always do that. and use differential torque for proper root position in medullary bone. When you move teeth such a big distances, you need to work on torque to get it where it should be. I'm going to conclude now and thanking again for all of you who were with me. I know some of you are very late at night, and life is short. Play hard, but enjoy life. And this was my pet, pug dog that I had. And she liked sunbathing. And in order to get some sun on her belly, she has to have her 2 feet against the wall. And I took this picture. She enjoyed it very much, as I hope you enjoy my presentation. I'm going to end up with a phrase from Uruguayan poet. We are what we do, but we are mostly what we do to change what we are.